Hello, everybody. My name is Valeria Caso. I'm a stroke neurologist from Perugia, Italy, and it's my great pleasure to interview Professor Bart van der Worp, who is the past president of the European Stroke Organization, and who will speak about the multi-center randomized trial of acute stroke treatment in the ambulance with a nitroglycerin patch, ASAP. So,
Mr. ASAP.
Bart, yes. But can you tell us a bit about this design? What was the rationale behind this very interesting trial?
Yeah, this was a randomized trial of nitroglycerin administered within 3 hours of stroke onset in the pre-hospital setting, so in the ambulance, in patients with suspected stroke. And the background is that previous studies had strongly suggested that nitroglycerin, if administered very early after stroke onset, would improve outcomes. This was, of course, in studies before RIDE2, which had a very similar design. And now, as you will know, in 2019, the British trial RIDE2 showed a neutral effect of nitroglycerin, but that was already when our trial was ongoing.
So, based on this rationale, you decide the trial, and how were the arms distributed?
So, patients were randomized to a nitroglycerin patch or to standard care, so there was no placebo before they arrived in the hospital. And this was, we used a deferred consent procedure. So patients were first randomized, and then the local investigator had to ask for deferred consent. And in the end, the trial was stopped prematurely for futility, also against the background of RIDE2, of the neutral results of RIDE2. And this was at the time we had included 326 patients.
And what do you think were the reason for this futility? So do you think nitroglycerin is now dead for acute stroke treatment, or is there any place for this treatment?
I think nitroglycerin is now dead, at least in the first 3 hours. There are colleagues who think it could be helpful in the in hours 4, 5, and 6 after stroke onset, and this I think is even currently tested. But certainly in the pre-hospital setting, this is nitroglycerin for stroke is dead.
What is the pity? Because in our settings where we have to distinguish between ischemic and hemorrhagic stroke, or we don't know in the ambulance, we do not have any kind of weapon to treat this patient prematurely. Do you see some alternative to nitroglycerin?
I think there are several potential alternatives in the field of neuroprotection, but of course all of these need to be tested again in a randomized trial. I think our trial and also several previous trials have shown that an ambulance trial in patients with suspected stroke is feasible. But to be honest, I would never do this again with a deferred consent procedure, because in our trial it proved that 14% of the patients who were randomized did not provide consent for several reasons for participation in the trial. So of these patients, we only have very limited safety data.
Did you include all patients with the consent in the trials, or only the one who confirmed the consent?
Yeah, we randomized 380 patients and included 326 patients in the analysis.
And what do you think were the reasons for the withdrawal of the consent?
Yeah, there were several reasons, but I think these reasons were mainly logistical, because patients were randomized in the ambulance and then they were, you could say, dropped at an emergency department in a regional hospital, of which the staff was fully trained for participation in this trial. But because emergency departments tend to be rather busy, it was often forgotten to ask for consent. And for example, the patient was already discharged home when local investigators thought about asking this, and then it took a lot of efforts for these investigators to chase these patients and ask for informed consent. And when the patients were already, for example, at home, or many other reasons, they apparently often didn't feel it was necessary for them to participate in this study.
And another point that I would like to ask you is about the distribution of ischemic and hemorrhagic stroke. How many ischemic and how many hemorrhagic stroke did you include in your study?
About 60% of the patients had ischemic stroke, and I think about 20% had intracerebral hemorrhage. The others had TIA or a stroke mimic. Of course, this also happens, that patients don't have a stroke. Yeah. And this was 10% of the patients had a stroke mimic.
10%, which is, I think,
it's very reasonable.
It's in line, yes, it's in line. So, do you think it's the first time? Was it for you the first time with sorry that I'm come back to this deferred consent, because I find this, I think, the most important point for the future, because every trial have to bring us something for the future. So do you think it's a part your experience, but in an emergency setting, would it be a good procedure? I understand that you had a lot of trouble because you had to chase the investigator, you had to chase the patients to find the consent. But let's say in other trials, would you recommend to do this? Let's say as a way to include more patients in trials.
Yeah, I think it's actually for such an emergency treatment, it's an ideal procedure in principle. Of course, there are several conditions. The treatment should be safe, and based on the first trials of nitroglycerin, we certainly expected this would be safe. But now, so if you can perform a trial in your own hospital and randomize the patients in your own hospital, then I think this is an ideal procedure, but not if someone else randomizes a patient and then a different person, different investigator has to ask for deferred consent, because it may then happen that the investigator doesn't have the time to ask for informed consent. So I would use it for future stroke trials. I think it's also ethical to use it because patients in the acute setting and also their representatives cannot oversee the pros and cons of any treatment. I think in the very acute stage, which is a lot of stress. So I think for this reason, deferred consent is also reasonable, but again, not in a pre-hospital trial.
I totally agree with you. So just another question regarding the distribution of risk factors. Do you find more hypertensive patients, or is this something that you think have influenced your the results of your study?
No, that's something I'm not sure about. One of the inclusion criteria is that a patient should have a blood pressure of 140 millimeters mercury or higher. So patients overall had a pretty high blood pressure, and in subgroup analyses, there was a trend towards better outcomes in patients who had very high blood pressures. So systolic blood pressures over 176 millimeters mercury. But of course, this was not, in this small group, not statistically significant. So the reduction in blood pressure caused by nitroglycerin may be helpful, in patients with very high blood pressures. But it's not something I would, with this drug, I would not repeat the trial in this patient group.
Okay, fully understood. Fully understood. Is there anything else that you want to add that you think that you feel that you didn't share with our colleagues?
No, of course, everything will be shared in the presentation, or has been shared, depending on when you watch this interview. But what's important to know is that we stopped this trial for futility. So there was no sign of benefit, but also no sign of harm overall in this patient group. What is important to note is that in patients with interstitial hemorrhage, we did not find a sign of harm at 90 days, in contrast to Bright 2. But there was a non-significant trend towards an increased risk of early mortality in patients with an interstitial hemorrhage who were treated with nitroglycerin. But at 90 days, there was a trend towards a reduced mortality in patients with interstitial hemorrhage who were treated with nitroglycerin. And this difference, this possible difference in outcomes, maybe due to the play of chance, but this is something we cannot explain.
Very interesting. Okay, I think your presentation was clear, and as you said, probably who will listen to our interview or knows already the results or is about to hear about the results. So thank you very much for sharing this with the whole Esoc community, with the Esoc community, and it's a pity that we cannot meet in person.
Absolutely. Ciao.